orientation program in KPC Medical College. So starting the day, we'll be starting with the otology section, chronic otitis media, squamous disease, and we'll be covering the case, CT scan, audiometry, mastoidectomy, and the tympanoplasty. The moderator of this session is Dr. Shaumendranath Bandopadhyay, and the faculties are Colonel Ajay Malik, Colonel Rohi Singh, Dr. Ajay Khawas, Dr. Shoma Ghotak, Dr. Shobhoshachi Gon, and Dr. Jayanto Shah. So I'd request Dr. Shaumendranath Bandopadhyay sir to kindly take the proceedings.
Good morning. We will be starting with the chronic otitis media. Traditionally, chronic otitis media is given as a long case, if it is available. If it is not available, then other cases will come. But you should be prepared to face crossings from chronic otitis media as a long case. So, we will discuss it in detail, but the time is short, so the faculties will have 5 to 10 minutes to discuss. So, some of the questions will be discussed and the rest of the important questions will be given to you as study material, either in the form of PPT presentations or Word files. So, you will find almost everything that are usually asked and the logical sequence of questions that come during the crossings of long cases. So, I will be starting with a case capsule, should I say. So, I will give you the details of the case we will discuss today in nutshell, and one by one our faculties will give you the questions and suggestions how to answer those questions. A 60-year-old male presented with the chief complaints of discharge from the left ear for last 8 years, hard of hearing in the left ear for 5 years, and recently he had the feeling of reeling of the head that is present occasionally for last 1 month and pain behind the ear for 2 weeks. The patient was apparently well 8 years ago when he noticed discharge from the left ear, which was insidious in onset but persistent in nature. The discharge was minded. Discharge is scanty, thick, foul smelling, dirty white color, occasionally blood tinged. The amount of discharge increases with cough and cold and partially relieved upon medication. Patient also complains of progressive hearing loss during the last 5 years in the left ear. There is also a history of reeling of the head for the last 1 month, which was insidious in onset and intermittent in nature. It was more with loud sounds, exposure to loud sounds, but the patient complained of the same reeling sensation even in the absence of any sound. It was associated with increased hearing loss in the left ear during the same duration. I will skip these things. You should write the history of present illness in details and examination of the ear. The pre-post-auricular region and the pinna were normal, no abnormality was detected. On otoscopy, in the left ear, the pars tensa was intact and slightly bulged with the white reflex behind it, some white mass behind the intact part of the pars tensa. Attic and posterior superior granulation was noted with crust and it bled on touch. Scutum seems to be eroded. Anterior and posterior malleolar folds are not identified. Thick, creamy, purulent, non-blood stained, foul smelling discharge in the deep canal. Skin of the canal is inflamed and congested. On the right side there is an attic dimpling. You should draw a diagram. Renew was negative in the left ear for 256 and 512 Hz, but positive in 1024 Hz, and on the right side it is positive for all 3 frequencies. Weber is lateralized to the left and absolute bone conduction test was reduced on the left and not reduced on the right. Vestibular function tests were normal. Facial nerve function did not reveal any abnormality. So, we came to the provisional diagnosis of left-sided chronic otitis media squamous disease, inactive stage with moderate mixed hearing loss with mastoiditis. On the right here, there is middle ear disc ventilation with mild retraction of the tympanic membrane with normal hearing. So, this is the case capsule, this is the patient we have. Now, we will go to the history part, how we will get the history and what are the points that we will stress upon. So, I will request Dr. Ajay Khawas to.
Good morning. So you get you should start the history taking for the COM case. Only thing that history and the examination will make the diagnosis around 100%. So your history and the clinical examination is most important. If you take the proper history, your clinical examination will be oriented that towards and you will take the diagnosis. So this is not how to take the history, I am not, this is the question, how did the patient describe the character of the discharge? Anyone?
Microphone.
Answer will be given by you.
So duration of the discharge, color of the discharge, smell of the discharge.
You discuss, you tell me, you have heard the discharge, you tell me.
Duration of the discharge since 8 years. So first asked
how the patient described his discharge.
Describe the discharge.
Describe the discharge.
Sir, what are the presentation in the initial stage? Initially the discharge was.
I told you how the patient described the discharge. You tell me once again. A squamous disease? Present with what type of discharge?
Mucopurulent type of discharge?
No.
Foul smelling?
How a patient of squamous disease describes his discharge from the ear?
Foul smelling, intermittent type of discharge, decreased on taking medication but not decreased as a whole.
Anything else?
Anything else?
Fishy smell?
Yes.
Foul
smelling discharge.
Yes, that is
it will be
okay.
recorded.
So foul smelling discharge.
That is recorded. Anything else?
It was thick in consistency
Yes.
and
Yes.
scanty in amount.
Yes.
Scanty in amount.
Scanty in amount.
It was not filling the whole of the ear canal, but
And he said that foul smelling, it may be blood tinged.
Yes.
that
Blood tinged. Anything
Okay.
else?
it was not relieved with taking medications and
Yes.
aggravated with the episodes of cough and cold.
With aggravated with the episodes of colds, but not relieved,
Not
complete
completely
relieved with
Completely
medications.
relieved.
Amount, color, consistency, সবটাই বলতে হবে. You will have to tell everything.
Everything.
Okay? So the description of the discharge should be complete. Okay.
First thing is the amount, whether it is a scanty or profuse. Second is the character of the discharge. Next is the consistency. Next is the color, smell, periodicity. And the patient should be, you have to write in the history in the patient language.
So mucoid, mucopurulent should be avoided.
Avoided.
It will be
We can
discussed
say,
when you give the summary.
Whether it is very profuse or thick,
And
Profuse,
consistency
thick, creamy.
creamy colored,
okay.
yellowish colored, you can say.
So sit down. Next. A patient with chronic otitis media.
what are the probable effects of the disease on hearing? Though the answer is written.
So it can be conductive hearing loss or mixed hearing loss, or as written in the provisional diagnosis that the patient had normal hearing, may present with normal.
No, you have taken the history, summary of the history already told by the sir. So what will be the hearing loss in this patient?
Sir, I think it will be mixed hearing loss.
Mixed hearing loss. It can be normal hearing.
Yes, sometimes if the cholesteatoma is blocking the perforation, so the patient may present with.
Have you ever seen a cholesteatoma blocking a perforation?
If the perforation
No.
is present
Cholesteatoma?
in the superior quadrant.
Due to cholesteatoma, the hearing is normal, but how, why?
Because sometimes the cholesteatoma can bridge the gap between
Bridge
the
the gap.
ossicles, known as cholesteatoma here.
Cholesteatoma here. What are the causes of mixed hearing loss? That means why the sensory neural component is developed in this patient.
Due to the proteolytic enzymes released by the disease process, the enzymes can, the toxins can,
Not the engine.
the toxins can enter into the inner ear through the round window niche or through the promontory in the internal ear. So it can cause damage to the internal ear, causing sensory neural hearing loss.
Can cholesteatoma cause destruction of the inner ear?
Yes, it can cause the, it can destroy the bony covering of the labyrinth.
So that also can be causes sensory neural.
So disease may cause,
And
the
also
treatment may also cause.
also the drugs.
Also the ototoxic
Drops,
drugs.
ototoxic drops. So
Next.
for the history taking, why the history taking is important? So from the chief complaints, you can make a broad hypothesis. And for the history of the present illness, you can narrow your hypothesis. And the physical examination, that will make you to go to the differential diagnosis. And the investigation, after the investigation, it will make you the diagnosis proper and the treatment will be followed. So this is the way, that's why every point for the history taking from the chief complaints to the diagnosis, every point is important. So already history taking, I am skipping these slides. So history of present illness, the red colored line, that is how you write into uninterrupted account of problem from the beginning to till date, not a paragraph wise writing. And finally, when you present the history, these are the important you have to follow. The simple language in a short sentence, following the manner just like telling a story. Speak clearly, slowly, and voice which is comfortable, audible, and avoid repetitions. Present the events in a sequence, chronological order. Always read with the summary. Details of the system review and negative history should be brief. Preferably negative history should be avoided if it is not required. And keep the track of time. Make a hypothesis. That's all for the history takings. The other questions
Will be shared with you.
Share with answer will be shared in the group. What are
Next,
the causes, fever, squamous muscle disease, that will be discussed that will be shared in the group.
Colonel Mollik will discuss the clinical examination part in very shortly in 5 minutes, but all the relevant questions should be shared with you. Do you remember the otoscopic findings?
Sir, as per the otoscopic findings, it seemed to be a grade 4 pars tensor retraction and a stage 3/4 pars flaccida retraction with outer attic wall eroded.
तो यहाँ slide था दे यार एक बार.
And there was some amount of.
Wait, he is just showing it again. Or revise it.
No. Tell me the finding.
Pars tensor seems to be completely retracted, touching the promontory. So I would put it as a grade 3/4 pars tensor retraction. And the attic is also stage 3/4 pars flaccida retraction with posterior superior area showing some amount of granulation tissue, crusting, and the scutum seems to be eroded. The outer wall is eroded with the scutum, and the anterior and posterior malleolar folds are not very clearly visualized. There is some amount of discharge and debris also noted along the floor of the canal, and the canal wall looks macerated and edematous.
When you're talking of the grades of retraction, that is one thing you may have to add. Okay, so we'll quickly go through whatever time permits.
Sir, may I add just one thing? That grade 4, grade 3 retraction, when you see the retraction pocket, when it is filled up, you don't know whether it is grade 1 or grade 2. So don't mention that. There is attic granulation, there is posterior superior granulation, it's all right. So whenever you do not see, don't say it. And there is a white mass behind the tympanic membrane, so it is not retracted, it is bulged. And you will confirm it by What's the said? The cingulation.
This is one
Sit
finding
down.
you may
Yeah.
like to mention, right. So what are your findings in otoscopy? We have just seen, we have just discussed this. And how do you elicit mastoid tenderness? Somebody? Blue
Next,
t-shirt.
next. How do you elicit mastoid tenderness?
Actually, three finger tenderness.
Yeah, where
can
do you
be
put the fingers
elicited,
quickly?
Sir, in the simpa conga and also.
Why?
Yes, sir.
Why?
So because the mastoid antrum is 1.2
Okay, great. Next. Next finger.
Then mastoid, one finger will be the mastoid tip in the simpa conga and also in the
Posterior border of
yes,
the
posterior
border of the post-oral groove, right?
Yes, sir.
Okay. Now, what are the findings in the TM you should mention? You mentioned a lot of things. Just repeat it. 1, 2, 3, 4.
TM findings, color of the TM,
Great.
retraction of TM, handle of malleus, if it's foreshortened or not.
So first mention the handle of
umbo is-
malleus, then go to retraction.
Five
So
minutes.
get your sequence correct in your mind. Okay.
Right. That's 5
If you
minutes.
have the handle of malleus, based on that you can do the retraction. Next.
Retraction.
Good.
Then sir, umbo, position of umbo,
Great.
and any
Then you
perforation
come
is
to
there.
then you come to your findings. Like we have a squamous disease.
Right.
Now first, what is very rightly said, he's talked of the normal things, and then you come to your target. Don't start target. There is the perforation and all that. First start like he's mentioned about the TM, the handle of malleus, what is obviously seen. Okay, and then you come to the findings. So what you have to just check is, in this case, you must mention about whether it's what type of perforation, if it is there, is it a marginal perforation, and if it is a marginal perforation, does it involve the annulus? How are the margins? Is it going inside? Is there squamous? Because this is going to prompt the examiner to ask you what are the theories of cholesterol formation. So when you talk, you should be able, with your confidence, when you read and keep reading, you can lead the examiner to ask you certain questions. Okay, so when you prompt him in this way, ki, sir, the margin is there, he will ask you this question. So that's why you get 2 marks. Right, so retraction pocket, cholesterol debris, you must mention about an oral polyp, yes or no. These are must know. If it is not there, you can mention that it is not present there, right? Then otoscopic findings, we have to mention about, like it's already brought out, whether there is keratin debris, which is a place you are seeing that. Is there any granulation tissues, right? Any foul smelling discharge has already been mentioned, any polyp or any bony erosion, especially if the scutum is eroded. You must mention that. So attic changes are also to be mentioned depending on what is there, whether retraction, whether there is any cholesteatoma seen in that, whether you can see the apex, you see that is also to be mentioned. So based on that, next person please, what is the SAIDS classification, any idea for the past tenser? We mentioned, next, quickly, if you remember.
TOS and SAIDS classification, TOS for flaccid and SAIDS for past tensor retraction.
Yeah, we are talking past tense.
We have mild retraction and grade 1. Grade 2 is tympanic, the past tensor will be retracted. It will just touch the, there will be mild retraction.
It is not adherent, right?
So it touches the
Then adherent to
promontory.
promontory, and then fourth is retraction with complete. Right, so this is the day. Then you have other 2 also, you may know the names. Now we come to, okay fine, sit. Just remember that, you should know the SAIDS classification
So
and the
in
TOS.
the earlier slides, grade 2 was touching the promontory, it was written.
Yeah, second touching but mobile. You can,
That is grade 3 and 4, no?
3 and 4 will be
Grade 3 is touching the promontory
Yeah.
and grade 4 is adhesive, like
adherent to that, correct, yeah. So what is the significance of, let's say what is the TOS classification? She mentioned about TOS, anybody? Yeah? No, next.
So pars flaccida classification, grade 1 is mild attic dimple, grade 2 is touching the handle of the malleus, neck of the malleus.
Neck. See, if you do not know the specifics, at least mention these, okay? It is touching the ossicle, not cleaning, bone erosion and definitive signs of cholesteatoma. Okay, now what are the signs of an active disease? We have mentioned the diagnosis, active disease. So these are the signs of an active disease. If there is discharge, granulation, polyp, foul odor, okay, and keratin debris which is seen. Right. Now, what is the DD of a white debris on TM? One is obvious. Obvious what?
Squamous disease. So what is
What do
the
you see? White debris key. What is it? Next.
next? Piche.
It can be cholesteatoma,
Yes.
it can be keratin plug, it can be in non-cleaning here of the
Very good.
creatine debris, and also
So you have automycosis, tympanosclerosis.
it
and
can
also
be
can
Candida species of
into that.
automycosis.
Yeah. Good. Now there are 3 layers of cholesteatoma. Okay. So what are the 3? Anything? Ultrastructure.
Sir, it is only clinical examination.
It's only clinical. So we'll stop here. These slides will be presented to you, right? You can go through those things about what are the layers of cholesterol. Some examiners would like to ask that. Thank you.
What file today?
So these are the.
We'll share all these rest of the materials with you, and if it is required, you can call sir directly because the name is written there. So you can call sir directly for any clarification. So you have seen the patient, you have examined the ears and the other structures, but you will have to present it. You will have to write down the history because that is the document you are handing over to the examiner. He will have your comments in writing. So every point, every feature from chief complaint to the summary will point towards your diagnosis. Every part should point towards a diagnosis. You are writing mucopurulent discharge and at the end you are saying that it is squamous disease, it will not do. So every point should be directing towards your diagnosis. I will share this word file with you. It is written by one junior resident and I have corrected it. So where do we go wrong and how should it be written? Okay. Some points that chief complaints will be chronologically placed and you need not have to write a sentence. You write the chief complaint dash duration and start with the complaint, not with the year. Left ear discharge, no. Discharge in the left ear or discharge from the left ear in this way. And the history of present illness which will be written from the beginning, from the onset. Next comes the examination after the general survey. You write down the findings of the loco-regional examination. If it is a ear case, you will start with examination of the ear. Don't write the systemic examination first. So systemic examination will come last and you will have to write the findings of the ear, nose, throat in detail, not only the ear. So what is written here is that this junior resident has written the details of the ear, but he has not written the details about the nose and throat examination, and the neck examination should also be done. Now, as you are appearing for a postgraduate examination, vestibular function test must also be written and mentioned. These points should be mentioned even if you do not find any positive findings there. Now, the tuning fork tests, either the Dini test will be positive or negative, write pos or neg. If you write negative and your competitor will make another stroke and it will become positive. So in practice also you make it a habit that you write it positive or negative. Weber will lateralize and absolute bone conduction test will be reduced or not reduced. So in different way it is written. So I have corrected all these things. You write down the summary. Summary should tell you all, should contain all the positive findings and important negative findings. You will have 45 minutes to write down your history. So don't make it unnecessarily elaborate. And after summary, you write down the provisional diagnosis. That's all. Now I will request Dr. Jayanta Saha. So Professor Shah will be talking about the diagnosis and pathology. What is the provisional diagnosis in this case?
My provisional sir আমি এজটা জানি না স্যার My provisional diagnosis আমি এজটা জানি না of dash male female is active squamosal variety of chronic otitis media without any complications.
Without any complications. But there is mastoid tenderness is present.
Sir, I presented late. I didn't know this case. Sir. Yes.
Pass it on to him. Are you present from the beginning?
Yes, sir.
Okay. Now tell me the diagnosis.
My provisional diagnosis is 46 years old male.
That is summary. Diagnosis.
Only diagnosis. Only diagnosis. Case of
sir, active squamosal disease. Discharge is scanty in.
Next.
This is a case of left-sided squamous COM, chronic otitis media, active variety with mastoiditis, and on right side there was mild attic dysventilation with intact TM, and there was a moderately severe mixed hearing loss in right side and normal hearing in left side.
no, it is only left
Normal
side.
hearing on left side. Left side is
Normal
the disease.
hearing.
Oh, sorry, sir. Left side a moderately severe mixed hearing loss and right side a normal hearing.
Fine.
Yes, mastoiditis.
Next one. What are the points in favor of your diagnosis? Tell me some points from history, some points from examination.
Sir, history I didn't listen. I came late. Examination part.
Pass it on. Who has come late will not answer.
So the points in favor of my diagnosis would be the discharge was first of all it was scanty in amount, and it was scanty in amount, purulent in nature.
Duration of the discharge.
Okay. So duration of the discharge was
suppose 10 to 15 years. Suppose probably 10 years.
So it was chronic.
Next amount.
So amount was scanty and it was purulent in nature with blood tinged, and it was foul smelling. And
That all suggests the
that
squamosal variety.
Yes, sir. It is suggestive of squamosal.
Anything
disease.
else from history? Hearing? Regarding hearing, anybody? Progressive hearing loss?
Yes, sir. The hearing is also progressive.
Anything?
You came late, na? Pass it on. If you are late, don't answer.
Headache?
Yes, sir.
Any headache?
Yes, sir.
History
There
of
was
headache?
reeling of head was present as a chief complaint of the patient.
And headache,
from
pain.
Reeling was there, pain was there as a chief complaint.
Where was the pain?
Discharge, hearing loss, reeling of head and pain. These four.
Where is the pain?
Pain
Pain was present because of the
exact location?
In the post-auricular region, pain was present because of the presence of active inflammation as the patient had mastoiditis.
Good.
And someone
to time to that.
From examination?
From examination, when we did the 3-finger palpation, there was tenderness that was present in the post-auricular region.
No. Findings. Otoscopic findings that suggest a chronic otitis media, squamosal variety.
Okay. So on the left side, there was presence of, in pars tensa region, there was presence of bulging of tympanic membrane with a white mass behind the tympanic membrane. Also in the pars flaccida region of the left side, there was presence of scutum erosion. It was present. And on the right side, there was presence of attic dimpling in the pars flaccida region.
What about the granulation?
Along with granulation tissue.
Granulation is the main finding.
finding. Yes, sir.
And what do you suggest that this adherent white crust in the attic, what it may be?
So it can be a debris, it can be otomycosis, it can be it can be a cholesteatoma flake. If the patient was on steroid drops, it can be steroid flakes as well. There are many DDs of that.
If it is cholesteatoma in attic region, how the mastoiditis formed in your case? Probably there is also an invasion of mastoid antrum from the attic region.
Yes, sir.
With the cholesteatoma. How it can spread from attic to mastoid antrum?
So
What
via
is the
attic
pathway?
aditus antrum we have the pathway.
How? Anybody else? Anybody?
Sir, there will be like negative pressure created in the mastoid that will lead
That
to
is
the
not my
formation of the
question.
cholesteatoma.
Question: how cholesteatoma proceed from the attic region to mastoid antrum?
Through the aditus.
That is pathway from Prusak space to
আচ্ছা তোর এখানেই আছে pathway
First
spread.
space involved in attic, Prusak space.
Yeah.
Then from Prusak space to superior incaudal space. From via lateral malleolar fold and gap between lateral malleolar fold and lateral incaudal fold. Then superior incaudal space to aditus to mastoid antrum.
ঠিক আছে এরপরে
সবই আছে।
আচ্ছা
প্রসিড করুন।
হ্যাঁ ডিফারেনশিয়াল ডায়াগনোসিসটা বল।
ডায়াগনোসিসটা বলে
হয়নি না?
হ্যাঁ ওইটা বলে বলো তো তুমি বলো তো।
What are the differential diagnosis? Ochira.
Chronic suppurative otitis media.
In this case, what are the differential diagnosis? Next one.
In front.
Acute otitis media.
Sir, all the points suggest towards squamous variety
Differential
of
diagnosis
COs.
comes in the differential diagnosis, na?
Can you think of any other disease other than cholesteatoma, other than squamous
Malignant
disease?
otitis externa.
Keratosis obturans.
60-year-old man with fleshy mass that bleeds on touch. So what comes to your mind?
Malignancy.
Glomus jugularis.
Malignancy, you should think about malignancy first. So malignancy comes to your list just after this one.
But malignancy, in case of malignancy, a short duration, na?
8 years, 8 years. Okay. Here in the study material you will find how the cholesteatoma spreads. This is from the attic region and the next one is from the posterior superior region. So this is how the attic region, attic cholesteatoma and the posterior superior cholesteatoma spreads. Okay. You will find it and you remember how cholesteatoma spreads, how cholesteatoma erodes bone. So we will be stopping here now. I will ask Dr. Soposachi Gaon. Do you know how to draw the diagram of tympanic membrane and the disease? You should practice it. It is here. So, Dr. Gaon will.
Good morning, everyone. So, this is a case of, now we have established this is a case of left-sided chronic otitis media squamosal variety, active. What are the investigation that you are going to advise and why?
Microphone.
So, what are the investigations that you want to advise?
Sir, I would like to confirm my diagnosis with some investigations. Some will be general investigation investigations to
Forget about general investigation, come to the special
other than
investigation.
that, we will perform some audiological investigations and
Right.
some radiological investigations.
Anything else?
I also we would like to perform an examination under microscopy.
Right. Anything
And
else?
if the setup permits, then we would like to do an endoscopy as well.
What is that endoscopy known as?
Otoendoscopy.
Otoendoscopic examination. So how, what are the benefits of otoendoscopy over the
Next one.
examination under microscope?
Next one.
Both are actually complementary to each other. This examination under microscope and this autoendoscopy, they are complementary to each other. They are not fighting against
These two are also complementary to each other.
Okay, sir.
Yesterday, they answered almost 90% of the questions.
Okay.
Now, start.
So what are the findings that we will get from examination under microscope? Tell me first that.
Sir, according to this case, what we were able to see was, we saw that the pars tensa was bulging and there was a white mass behind the pars tensa. The attic region consisted of white debris and the outer bony wall was eroded.
That is the otoscopic examination. What extra information that you are going to
Sir,
get or you want to know from examination under microscope? And what
Sir,
other
we
thing you
will-
want to do while doing examination under microscope?
Sir, we will be able to do suction clearance and see the attic region better. We will be able to understand if it is keratin debris or cholesteatoma flakes. We will be able to understand if we are able to clearly see the fundus of the sac or not.
Yeah. Do you want to take the discharge for any examination?
Culture sensitivity can be sent.
So one is microbiological examination,
Yes,
another
sir.
is audiological investigation, another is radiological investigation, and fifth is visualization. Visualization with the help of examination under microscope and autoendoscopy examination.
Yes.
Please pass the mic. So what are the advantages of autoendoscopy over microscope?
Sir,
Not in this case, in general.
Autoendoscopy, sir, provides a better, higher definition picture, first of all.
Yes.
We can understand the dimensions of the retraction in a
Like in this case,
better
there
way.
is no such retraction. You can see this is the whole area is filled up with cholesteatoma. You
Yes,
will, even after suction clearance, you will see that the cholesteatoma matrix is going deep inside. So, any other extra information in this case and in other cases? Okay. Say, suppose this is the inactive squamosal variety. You can see a retraction pouch is going posterior-superiorly. So, do you get any other advantage while doing endoscopic examination?
Sir, we can we can see the fundus of the sac.
Right. So you can see you can reach up to the fundus with an angled endoscope or even with 0-degree endoscope wide angle. You can get a very clear picture whether how far is the fundus is going and whether there is any retained debris there or cholesteatoma is there or not. Okay. By that we can divide this squamosal variety into active and inactive varieties. Right. So next one is, can you read this audiogram? Anyone?
Next, in front.
Sir, shows patient's audiogram. In right side, it's within normal limit.
Please try to say pure tone audiogram. Don't say
Pure tone audiogram. And in left side, there is bone conduction is
Next one.
Sir, in the left ear there is, so that is right ear. No sir, there is, the right ear is within normal limits with high frequency loss. With high frequency sensory neural hearing loss, but in the mild. In the left ear, there is a moderate conductive hearing loss with a sensory neural component at the high frequencies. Sir, the airborne gap is
How do you calculate that?
approximately 30 decibel airborne gap.
How do you calculate that?
Sir, I will take the average in three frequencies: 500 Hertz, 1000 Hertz, and 2000 Hertz. So these are the speech frequencies.
So we are taking consideration of these frequencies 500, and we are giving the gap 1K and 2K, and we are taking average of these three frequencies, right? Can you tell me whether there is any bone conduction has been done or here or not?
Sir?
If there is any bone conduction or not?
So bone conduction is there. There is masking. Masking has been done in the bone
Why
conduction.
bone conduction is necessary in this case?
So why is
Why
bone?
bone conduction is necessary in this case?
Sir,
bone conduction masking is necessary in this case. Sorry.
Sir, we want to diminish the interorder attenuation as much as possible, so that the other ear does not aid in testing
So
of
what is the interoral attenuation in case of bone conduction?
Sir, sometimes when we are going, when we give a frequency to the test ear, the bone.
You listen the question.
What is the interoral
Digital answer. Digital answer.
For bone conduction.
What is the interoral attenuation for bone conduction?
Approximately.
For bone conduction.
For bone conduction. Listen to the question.
Listen to the question.
It is 0 decibel.
0 decibel.
Right? And in case of ear conduction?
Sir, approximately 35 to 40 decibel.
There are two things. One is whether the earphone is inserted into the ear canal or whether the earphone is over the pinna. If it is over the pinna, then it is 40 decibel approximately. And if it is in the ear, then it is 50 to 55 decibel. So that much of masking is necessary. So we can move to the next.
That masking is necessary always for bone conduction. The next question is, would you accept the audiogram?
Yeah. Would you accept this audiogram? According to your history, clinical examination, you are considering some airborne gap or conductive hearing loss or sensory neural hearing loss, and now you are getting this audiogram. Do you accept this?
So you have done all these things. Would you accept this audiogram or not?
If you are going for surgery in this case, then what should be the operative finding? And will that match with this airborne gap?
Yes.
Yes, sir.
You are going for surgery, you are doing surgery in this case, and the operative findings is this airborne gap 25 to 30 or 35 decibel of airborne gap, will that match to the operative finding? Do you think that all ossicles are intact here only and this hearing loss is only due to the perforation in the tympanic membrane, or if there is any ossicular necrosis? I am just making the question bit
there may be ossicular necrosis because
which ossicle goes first?
Lenticular process of incus.
Followed by?
Followed by long process of incus.
Long process. After that?
After that, stapes suprastructure.
Next person, please.
This question was put for one simple reason, is that on the other side the audiologist, due to hurry, did not go for masked bone conduction test.
Yes.
So without masking, we will not going to accept any bone conduction. That's why the question was said whether you will accept this audiogram or not. No, bone conduction tests without masking is not acceptable in any case.
Now can you tell me the Austin cartoons?
No. What your question? Why lenticular process is more vulnerable?
So because it has end arterial supply, the nutrient artery which it receives, single arterial supply, that's why it is more vulnerable to any destructive process or any inflammation.
That's right. Okay.
Next what sir asked, that is this magnitude of conductive loss, do you think that this is appropriate according to the history, and if not, why?
So the intra findings may vary from the pure tone audiogram, but the hearing loss that is present intraopic, there might be cholesteatomatous hearing.
Exactly,
that's why
that is the bridging by the cholesteatoma might
yes,
be
sir.
there. That is what you have to say. No?
Yes, sir. That's why the AB gap is not that much as compared to the pathology.
Now we will be with Dr. Soumya Ghatak with CT scan.
So you know, you have taken the history, you have done the clinical examination, we have seen the audiometry. So what is the role of CT scan? What is the role of radiology now? Next stage.
In CT scan,
What is the role of radiology?
The role of radiologists see the bone erosion, the dehiscence of the facial nerve canal, the ossicular status, the middle ear status, whether there is any mass, whether there is any soft tissue filling the ear.
So the first thing you want to see is the extent of the disease,
Extent
because with a small attic perforation also you might have a very big cholesteatoma which is going into the middle ear mastoid and all the things. That is the first thing.
Yeah.
Second is what the disease has caused. So that's what you are saying, the extent of bone erosion.
The destruction and the status of the entire middle ear, including the additus, not the additus, the mastoid region, the status of the mastoid region, and more importantly the ossicles and the facial nerve.
Exactly. And the third thing is complications.
Complications.
Whether there is any complication related to the bone erosion. And that will help you do what?
For my when I perform the surgery, I will get an idea about what is the displacement of
the... So radiology is basically the roadmap for planning the surgery.
For the otolaryngologist.
Yes. So what are the possible investigations you could have done?
In radiology?
Yes.
In radiology, earlier we used to do the X-ray mastoid, but nowadays definitely the high resolution CT scan of temporal bone is preferred.
What is the drawback of X-ray mastoid?
We cannot see the ossicles, we cannot see the higher definition structures because the temporal bone is a very small region. We need to see every cut.
We cannot see the minute bone
structures
and it can only show you a low-lying dura and a forward-lying sinus only, right?
Only the sinus plate and the dural plate will get an idea about that, and probably the pneumatization of the mastoid.
Exactly. What is the difference between pneumatization and aeration?
She gets 80%, I think.
What is the difference between pneumatization and aeration? Since we are in the topic, we will just discuss.
Aeration is the natural existing pathway of ventilation of the middle ear and the adductus and antrum, and the pneumatization is the air cells that is there since Partharki. While
what you said is natural pathway is ventilation pathway. Okay. Pneumatization is the number of air cells that you are having. So you can have a sclerotic mastoid, you can have a diploic mastoid, you can have a pneumatic mastoid.
Yes.
And what I wanted to hear is you can have a pneumatic mastoid, but aeration may not be present. When you are having a middle ear effusion, it might be a very well aerated well pneumatized mastoid, but there is fluid in all the cells. So it is pneumatized, but it is not aerated because of the fluid. So you have to understand the difference. And how will you see that on radiology?
In case of X-ray mastoid, we can appreciate that.
X-ray you cannot see. Pneumatization versus aeration.
The pneumatization can be appreciated in case of...
Yeah, you can see the pneumatization.
Yes.
So CT will tell you that whether there is soft tissue density, but there is preservation of the bony septa, right?
Yes.
If the septa are there, that means it has not been eroded. So it is pneumatized without erosion, but it is not aerated. So when you have fluid in the middle ear, you have to recognize that. Okay? Fine. So we are going to CT scan of the temporal bone. High resolution CT, she has said. What is the difference between normal resolution and high resolution?
Sir, in high resolution CT scan, the difference is the cut in the CT scan.
Width of the cut.
Yeah,
very good.
Cut.
So what is the width you want to take for the temporal bone?
Sir, 1 millimeter.
1 millimeter. So you are cutting it at 1 millimeter intervals. Why do you want a high resolution?
So we can see the minute structures as
exactly. The magnitude of structures is so low that you need smaller cuts.
Smaller cuts.
Okay. So we generally take the axial cuts, right? So how are you going to read the axial cuts? From which way?
Start from the below upwards.
Right. We can start from below upwards, but we
start from the temporomandibular joints.
Why the temporomandibular joint? It is at the level of the external auditory canal, which is just at the middle. That is the level at which you take the plane, not the level from which you read the CT. That has been done by the technician already. So your job is to read the CT. You can read it from below upwards, but generally we prefer to read it from above downwards because above you have less number of structures. So you can identify the arcuate eminence formed by the superior semicircular canal and read it downwards. As you go down, there are a lot of structures in the skull base, so that we read it from above downwards. Okay. So we will read it from above downwards and I'll stick to this CT only. So you can see that this is the upper part and we are going to read it. There is a soft tissue density within the petrous apical region, okay? And there is bone erosion here. So you can see that there is a bony gap here. Can you see, appreciate it? Is it appreciable there? So this is the middle cranial fossa, right? Because here the temporal lobe is resting, so you have a gap in the middle cranial fossa bone. And then as you go down, it's not visible, it's wherever you lateral fissure. If you look at the lateral, anyway, it's not visible, so we'll just discuss it. From the history, your patient is having a headache, right? So what can be the causes of headache in a case of COM?
Sir, the headache could be due to mastoiditis, or there could be some complication like petrous epicitis or lateral sinus thrombophlebitis.
So any intracranial complication starting from extradural abscess onwards can cause headache. Okay. So, and any other cause of pain?
Sir, Gradinikos syndrome could cause.
What is Gradinikos syndrome?
Deep-seated retroorbital pain.
That is the Gradinikos triad.
Oh, triad.
What are the components of the triad?
Sir, deep-seated retroorbital pain, diplopia, and discharging ear.
Deep-seated retroorbital pain?
Diplopia and discharging from the ear.
Seen in a case of petrous apicitis. So, why you are having deep-seated pain?
Sir, because of the involvement of the trigeminal nerve.
Where?
At the Dorello's canal. Meckel's cave and the Dorello's canal.
Dorello's canal is for the sixth nerve.
Oh no. Sir, Meckel's cave.
Right. And Dorello's canal is formed by which ligament? Anterior petroclinoid ligament or Gruber's ligament, isn't it? Right. So the issue is there is involvement of the petrous apex here as well, but it is not going up to the entirety there. And then patient was having reeling of the head. So we are expecting, and it is there is a lateral canal fistula. Okay. So what are the things that you want to see on CT? Structures that you want to see?
Overall or sir, in just
overall, let's hear it because we can't see it all here.
Sir, we want if you are going from above downwards, we want to see the bony labyrinth. If there are any fistula or congenital abnormalities, then we also would like to take a look at the course of the facial nerve in the fallopian canal, and the status of the ossicles, whether the extent and the spread of the disease, and if there are any signs warning us of any possible complications.
So when would you like to do an MRI?
Sir,
Just wait. So here you can see that this is the lateral canal, and there is this lateral canal is so you can see the lateral canal is open into the cavity. So you have a lateral canal fistula here, also seen in this one, right? But if you look at the fallopian canal, this is the one. You can see the tympanic segment of the facial nerve that is also eroded. Okay. So one thing that you have to keep in mind here is that whenever you suspect a complication, you might open up the ear and not see it. So then you cannot blame the radiologist, because what we are doing in CT scan is we are acquiring the information in 3D, which is known as a voxel or volume element. And then the computer is processing it into 2D because you are seeing the picture in 2D. Okay, and that volume element, when it is being compressed, it has radio densities of various radio densities. You have bone, you have soft tissue and air. So when these three are together, what it does is we have what is known as a volume averaging defect. And when there is very thin bone between two soft tissue densities or between soft tissue density and air, the computer might misinterpret it, and you might see the fistula here, but it might not be there. But at least it will make you aware that the bone is very thin, and whenever there is thin bone, you are supposed to look out for fistula and keep that part for the last while you are operating, because that will prevent the unnecessary SN loss that you might encounter. Okay? Can you describe the CT scan, as sir is saying? How will you describe the CT?
This is showing on a high definition CT scan, CT temporal bone, which is showing the I'll just in axial cut or a coronal cut I have to discuss that. Then I'll have to tell that I am seeing the tegment part of the.
Then one more thing you have to mention, which is the window.
Yes,
because window makes a lot of difference.
Or a soft
exactly.
tissue window, we have to say that.
For CT scan, what do you prefer?
Bone window.
Bone window, yes, because it will show you the bony details.
Yes,
right. And then
we will tell about the tegment part of the
so it is a high resolution CT scan of the temporal bone showing bone windows. Showing the first thing is
we have to tell the normal things which we can see over here. Then we will go to the pathologist.
Such an extensive disease, sir. এখানে তো normal বলার কিছু নেই. There is a soft tissue density which is occupying which parts we have to mention.
Yes,
middle ear, attic, mastoid, and showing here what we
bony
show.
destruction, ossicular change. If there is any ossicular discontinuity or
First that you mentioned here, there is tegmen erosion.
Yes, tegmen erosion.
So first is you are seeing tegmen erosion.
Yes,
then you are seeing.
Then after tegment part, then will coming into the vestibule parts. Then we have to.
What did we see here?
Soft
lateral canal.
Oh, actually.
Fistula of the lateral
semicircular canal. Yes, sir.
And then we come down. We saw the
ossicles. We have to check.
Before that, we just saw tympanic segment of the facial nerve was eroded. And then we will address the ossicles. Ossicular part, if we see, we can see it here. So on the coronal cut also it is visible. You can see the tegment dehiscence here. You can very well see the lateral canal fistula. It is open here, here also. And you have to look for the ossicles. On this side, the ossicles are visible. You can see the malleus here, but here no ossicles are visible. Okay.
Yes, sir.
So you have to mention about the ossicular erosion status. Right. So if you summarize it, what you are going to see? We are seeing the HRCT scan of the temporal bone, of which side you can mention in bone window, and it is showing first thing is whether there is a soft tissue density. What is the hallmark finding of cholesteatoma? It is the non-dependent, because this is an extensive disease, you don't have to care about that. But as I said, for pneumatization versus aeration, if fluid is there, because cholesteatoma cannot differentiate between soft tissue like the cholesteatoma sac or whether there is fluid. So if it is limited disease, you are going to have a non-dependent. Patient is being imaged in the while he or she is supine. If there is fluid, it will go down to the most dependent part, but cholesteatoma will not. So it is a non-dependent soft tissue mass which is occupying whatever it is occupying, and then you have with evidence of erosion off. First thing that you have is the vestibule, then you come down, you have the fallopian canal, then you come further down, you can have the, first was the tegment plate, then the vestibule, then the fallopian canal, then you come to the ossicles. You have to go systematically, from above downwards if you are going, so whenever you are representing that also, you go systematically, you will not miss anything, right? So
just tell me what we are projecting. Is it a bone window or soft tissue window? This one?
So it's a bone window.
Yeah.
Okay.
Bone window actually.
Okay.
So as I asked him, when will you look for MRI?
So
you will do MRI in all cases?
First.
You want to do MRI in all cases of cholesterol?
So if I'm suspecting soft tissue.
না না এখানে আর কোশ্চেন নেই
soft tissue
ওটা পরে আসবে আবার এখন এখন রয়েছে
MRI has the incapability to image bone. So in cholesteatoma, the hallmark of the disease is bone erosion. If you want to know the extent of bone erosion, you cannot depend on the MRI.
MRI, yes.
Why cannot MRI not image?
We can check cholesterol diffusion weighted MRI. We can
come to
see.
that.
No, we can.
Huh? Why? What are you imaging in MRI? That is what I want to know. Exactly, hydrogen. You are giving a magnetic field orienting all the water molecules, the H plus dipoles in a same orientation. Okay. In the human body, they are all scattered. What you are doing is you are putting the patient in a magnetic field. So all the poles are oriented in the same direction. Then you are sending a photon. That photon will displace one hydrogen that will go to a higher state. Then when it is coming back, it is giving other photons which are then progressing. So if you, in bone, you do not have mobile water particles or hydrogen atoms. So you cannot image bone. Right? So when will you use MRI?
So if I'm suspecting any intracranial complications.
Exactly, intracranial complications. So in this patient there is tegment defect. So you have to do an MRI. Okay. And in the fallopian canal also there is a dehiscence. So it can show you the extent of enhancement and show you what can be done. And as she was saying, in revision cases, we do not, CT will not give you the option of differentiating between granulation tissue and cholesteatoma. So there you have to do MRI and you have to do diffusion weighted imaging, non-EPI, non-ecoplanar diffusion weighted image, which will show what will be the finding. Any idea? In cholesteatoma there will be restricted diffusion and it will appear bright.
It will appear bright. That is the point.
Cholesteatoma will appear bright on non-EPI DWI. Okay.
Okay, sir.
Now we will be discussing the treatment options by Colonel Singh.
Yes.
This is your patient with mastoid tenderness, chronic otitis media, active squamous disease. What will be the initial management when the patient comes to you?
Initially we can go for something if there is an active discharge or the disease in an active process, we can go for a conservative management followed by definitive surgery.
For the left side?
Yeah.
Okay, and for the right side? What option will you give to the patient for the right side? The patient did not come with any complaint for the right side, okay. But your findings were there for the right side. So that needs to be followed up. So this is the answer. For the right ear, a close follow-up of the patient has to be done, and for the left ear, good oral toileting should be done. Also, this has been already explained that autoendoscopy versus examination under microscopy, you can go for it and take a swab for culture sensitivity, so that later on when you give antibiotics to the patient, it will be culture sensitivity directed antibiotic therapy. Okay. Now the second question is, what options do we have for definitive management? So for the left side, what will be the definitive management?
Ma'am, for the left side, we'll be doing tympanomastoid, the surgical approach will be the definitive management. We'll be doing tympanomastoid exploration and proceed under general anesthesia. Okay. So, ma'am, depending upon the otoscopic findings, we'll be doing canal wall down mastoidectomy.
Now then comes the option of inside out or outside in. That depends on the experience of the surgeon. Okay. The next is, how do you plan the treatment for this patient? So you have partly answered it, that you will go for a canal wall down. Okay. If the examiner asks, why do you want for a canal wall down itself? What will you say? When we were students, we used to say that with my amount of experience, I would like to go for a left tympanomastoid exploration and a canal wall down option. Yeah.
Ma'am, since we won't be taking, ma'am, we'll be directly going with canal wall down mastoidectomy, because this patient, if we won't, if we'll be going with a two-stage procedure, then it's not necessary that the patient will be coming to us regularly for follow-up.
So there are many reasons to it. Why do you want to go for a canal wall down versus canal wall up surgery? Okay, that will touch later. So the aim for this surgery will be, what is the aim for this surgery? The first aim is, you were correct, say?
Disease clearance.
Yes, very good. And the second aim is?
Improve the hearing.
Okay. So to provide a disease-free and safe ear, use these terms, okay? That will fetch you more marks in the Viva. The second is to reconstruct hearing if possible. How do you explain the patient? So how will you counsel the patient about this?
We have to counsel the patient for the surgery. We have to
counsel the patient that if he doesn't undergo
First,
surgery,
you counsel the patient about the type of the
type of the
disease
disease he's
okay?
having, and we have to say that if he doesn't undergo the operation, the
What
situation might worsen.
complications, yes, what complications he can
He
land
might
into.
have, he might undergo any intracranial complications,
Yeah.
any facial nerve dehiscence can be there. So we have to explain all of these, and we have to gain confidence of the patient.
And then explain the type of surgery
Type
to
of
the
surgery
patient.
we have to do,
Okay.
what anesthesia we have to do,
Yes.
and any other complication which might happen in that surgery.
Okay.
We have to explain that to him.
And post surgery,
Post surgery, we have to
follow-up will be required.
We have to
This
say
also
that
you
he
have
has
to explain to the
regularly
patient.
come to us for follow-up.
okay. So now when you tell the patient about the follow-ups, you can assess whether the patient will be able to come or not frequently, and then you decide upon whether you will be doing a canal wall down surgery or canal wall up surgery. Okay. So in the language which the patient understands, you will explain the patient the type of disease the patient is having, that is having a bone eroding property, and it may further spread. It needs urgent treatment. The first aim is to remove the disease, and the second aim will be to reconstruct the hearing. And then you will explain the patient the type of surgery, anesthesia, the follow-up, and further post-operative care to that patient. Also the restriction of activities which might be involved in a canal wall down mastoidectomy. Also the complications of not treating the disease and the possible complications and sequelae of the surgery has to be explained to the patient in simple words which the patient understands. So in this case, with the amount of disease and age of the patient, will you go for a canal wall up or intact canal wall, or a canal wall down mastoidectomy? Why? And state few advantages or disadvantages of the same.
Next to the.
So the patient is 60 years in age. Okay.
Ma'am, in this case, I will go for canal wall down mastoidectomy because as this is a squamosal variety of disease, so I need to remove all the disease cells and the structures, just except the full.
The patient is also having, in radiology we saw something, the patient is also having
semicircular
lateral semicircular canal dehiscence as well as tegment plate erosion. So a canal wall down surgery will provide us with better access of dealing with these complications also.
Yes.
And seeing the age of the patient as 60 years, it must be the last surgery for him, not a revision surgery would be required later on. Okay. The only thing is that the patient should come for follow-up because his mastoid cavity will require attention by the treating physician. So what are the advantages? Canal wall down surgery gives us with more visibility, easy access. There is a mistake here, please everyone correct in your slides. It will be increased chances of clearance of the disease, okay? And good post-op care and follow-up will be there. Early detection of any recidivism if it is there, okay? Now would you prefer to go from, so there are two ways of providing this question, anterior to posterior or inside out, or from posterior to anterior, that is outside in surgical approach. So what will you prefer? Inside out approach or outside in approach?
Madam, we will prefer inside out approach.
In this case?
In this case.
Okay, then what is the advantage of that if you are going for an inside out?
If you do inside out approach.
What is inside out approach? The examiner will ask you.
We will drill the attic area first, and then we'll move toward the
follow the disease and move
towards the mastoid antrum.
Okay. So what is the advantage for that?
Madam, if we have a low lying dura or a antepost sigmoid sinus, then we can approach accordingly.
And
also if there is contracted mastoid,
you will give a small mastoid cavity to this patient. Inside out will always create a smaller mastoid cavity which will be healing faster than an outside in. So in inside out, the attic is opened first and the disease is followed posteriorly till the antrum and mastoid cavity. Okay. The advantage is that we provide a small mastoid cavity which heals faster, and a better middle ear reserve is there and better hearing outcomes are there. The disadvantage is that there is a chance of residual disease. Okay. The opposite happens in outside in. The mastoid cortex is delineated, antrum is identified, then we follow the otitis and then we go to the attic. So in this case, what happens? We provide a larger mastoid cavity, but then it has to be obliterated so that it heals faster. What are the disadvantages of
may I add
sir,
something? So your answer was very good, but your answer should be patient specific. In this case, there is extensive bone erosion. There is no question of any small cavities. There is scrotum erosion, there is tegmen erosion, there is posterior wall erosion, there is labyrinthine erosion, there is erosion of the facial nerve. So both the inside out and outside in are valid. In this case, there is no chance of any smaller cavity. So you can also go through the posterior part. So you can also
access has to be very good.
Yes, access must be very good in this case. Thank you.
What are the disadvantages of canal wall down mastoidectomy? Anyone?
Canal wall down.
Disadvantages of canal wall down.
We will residual disease may be missed out in canal wall down.
Canal wall down residual is very less.
Disadvantage.
So here you will describe all the cavity problems. What are the cavity problems? What are the cavity problems which the patient faces?
Healing cavity, discharging mastoid cavity.
Okay.
4 Ds. I'm giving you a hint. There are 4 Ds for the mastoid cavity. Anyone?
Ma'am, discharge, deafness,
Yes.
and patient unable to swim. And
Discharge, deafness, dependence.
Discharge, deafness, dependence,
and
dizziness.
Okay, so the dizziness is because the air currents will affect his mastoid cavity. The second is dependence for cavity cleaning and proper follow-up. Third is discharge. If there is a high facial ridge is there and small meatoplasty is there, it will be a discharging cavity. Okay, and deafness because there will be decreased hearing. Indications for MRM. What are the indications for MRM?
Absolute indication, unresectable cholesteatoma.
Yes.
Intracranial extension.
They are the complications. Okay. So in this you divide it as absolute and relative. Okay. So absolute is unresectable disease. If the disease is extensive, as in this case, what sir has already described. Okay. The second is unreconstructible. Posterior canal wall erosion, okay. Then failed first stage surgery and inadequate follow-up by the patient. Then you go for a canal wall down or MRM, okay. The relative indications are, it's written there, read. Padho, kya hai?
So only hearing ear?
If it is only hearing ear, it is a precious ear. So a canal wall down is the safest surgery to be done, okay. The second is any otologic or intracranial complication. So here there are complications. There is lateral semicircular canal fistula number 1. The second thing is tegmen erosion is there. So we go for a canal wall down. Okay. Areas where cholesteatoma may be left mistakenly. While doing the surgery, we might leave few cholesteatoma at few places. So what are those areas? Hidden areas of mastoid, tympanomastoid region.
Sinus tympani.
Yes.
Pass your microphone to the next one.
Pass it to the next one, please. Yes.
Eustachian tube area anteriorly, then sinus tympani, some hidden areas in the retrotympanum, like facial recess or around the areas.
That comes under sinus tympani. That's okay.
Then
epitympanum?
Yes, epitympanum and anterior epitympanum if the anterior epitympanic recess may be
anterior epitympanum, posteriorly sinodural angle,
yes.
Inferiorly is
mastoid tip area,
sinus tympani and anterior protympanum, that is around the eustachian tube. So these are the areas where the cholesteatoma may be mistakenly left. And areas where cholesteatoma may be left to deal with in second stage surgery. So this is yet another question, where the surgeon knowingly leaves the cholesteatoma to revisit during a second stage surgery.
Try it, try it.
Those places?
Try it. You should try.
Sir, ma'am, areas where cholesteatoma may be left to deal with could be
second stage surgery.
second
So
stage.
what are those areas?
question answered.
So in the first surgery, you have cleared some amount of cholesteatoma, but you see few cholesteatoma may be left there, and we can revisit it in a second stage surgery. What are those places where you knowingly leave that so that
Yes.
you don't enter into yet another complication while removing the cholesteatoma?
Ma'am, in some cases of labyrinthine fistula,
Yes.
where we classify it as according to Donhofer and Miliansky,
That
and
classification later I will ask.
Yeah.
So labyrinthine fistula, so as to avoid any further trauma,
the
to,
trauma
the
to the
labyrinth
labyrinthine
or cause
fistula.
any labyrinthitis.
Yes.
Second?
And second is if there is any erosion in the tympanic segment of the facial nerve.
Yes, so
and-
that you don't further
Yeah.
traumatize the facial, nerve.
nerve.
You think that in the second stage it will become an cholesteatoma pearl, and then you will be better able to remove it. Okay.
Yeah.
The third?
Third, if we have any dehiscence of the sinus plate or the dural plate.
Yes. Okay. And
And
one more. One more. Chalo, I'll show it to you. So one you have already answered. It is over an exposed facial nerve. The second is semicircular canal fistula. The third is stapes foot plate. Okay.
opening the vest.
Because there might be risk of opening the vestibule, then this will cause sensory neural hearing loss. Okay. And adherent to dural or sinus plate. Very good. What are the difficulties or complications you have managed in mastoid surgeries?
Next.
So it's a very important question. During the mastoid surgery, what are the complications, or immediately after the mastoid surgery you see a complication?
Ma'am, after the mastoidectomy, most common is a facial nerve paralysis, and we have to give a steroid, and along with the physiotherapy management.
Anything else?
Ma'am, due to labyrinthectomy, there can be vertigo, and we have to manage.
During the surgery, any structures which you may disturb or you may traumatize, you may injure?
Ma'am, facial nerve
Facial you have
can.
already answered. Then, so this is very important and it needs to be read in detail.
Stapes, ma'am, stapes footplate can be injured.
I am enumerating just 3 of them, which is very important for you people. The first one is dural plate breach. If there is a small dural exposure of less than 8 millimeter, it can be left like that. But if it is more than 8 millimeter, but here in this case, what is there? The tegment is already eroded and it is a large one. So here we will need to repair the tegment plate. Otherwise, later on, due to its dependent position, the brain will protrude out and it will become meningoencephalocele or brain fungus in a chronic stage. Okay. So in this case, the dural plate has to be repaired with the help of either cartilage or with a bone chip from the cortical bone. The second is sigmoid sinus injury. What all can you do to avoid that injury? And if injury happens, what can you do? So if there is a small sigmoid sinus injury, an adrenaline soaked gel foam may be placed, but if there is a large breach, the finger should be placed over it and the patient should be given a head low position so as to avoid air embolus, and then you need to repair that breach. This is an important question. Please all of you read. It's given in Schambach, it's given in book by Toss. Okay. And facial nerve trauma. So there are 2 ways of asking this question. Suppose you have operated on a mastoid patient and post-operatively you find that the patient is having a facial nerve palsy which is incomplete. What do you do? Incomplete facial nerve palsy in post-operative period, immediate post-op period. What might be the reason? One is local anesthesia, the other is tight packing of the mastoid with the ribbon gauze. So the small ribbon gauze small piece have to be removed so that you loosen the ribbon gauze. There is no pressure over the facial nerve. We have seen that the tympanic segment is already exposed in this case. So if you pack very tightly, it might be causing a pressure effect over the facial nerve. The second is post-operatively you find a complete facial palsy of the patient and you are dead sure that no, you have not traumatized the facial nerve. What can you do? Observe the patient. You may start with steroids also. A good antibiotic cover and steroids. Okay. And if you are very sure you have already traumatized the facial nerve, you will not close the surgery and you will ask for help, okay, from a senior surgeon. And then if there is transection of the nerve, you go for a neurography or nerve repair. If the transection of the nerve is there, sometimes drill happens to slip. So large part of nerve is gone. So what you do, you put a nerve graft, okay, that's all. That's all. Thank you.
So there are many more suggested questions in this PPT presentation. You will get it. Yeah.
Provided in the reading material.
Thank you, ma'am.
So this part is also already ma'am shows told how to counsel the patients. These questions already passed. So what are the important points of the counseling? Anyone?
First, we will explain the disease process or condition of the patient.
Number one, the disease process. What is the patient having? Next.
Then the next management plan to the patient, the surgical, what surgery we will perform, and whether why he or she needs the surgery.
So second thing is the what are the treatment options patients have.
Yes.
So these patient, do you think any other options other than surgery?
Surgery is required, otherwise regular suction toileting will not help.
Next, the surgical option.
Surgical option.
Next.
And then we'll explain the surgical procedure to the patient, whether general anesthesia will be done, and what are the steps of what we'll do in the surgery, and then the complications.
The surgical outcome. What outcome you are giving to the patients? That means you have done the mastoidectomy, you have not explained that the patient's hearing will improve. Yes, you have to mention it.
Hearing may not improve.
May not improve because that the patient having the lateral semicircular canal fistula, dizziness may be properly not improved. So everything you have to counsel before the surgery. Particularly this mastoid surgery you have to counsel. Next.
Then the complications, common complications.
Next.
And he or she will need to follow up after post-operatively.
Yes. If you do the canal wall down mastoidectomy, there is a chances of regular cavity problem usually happen. If you even you do the cavity obliteration, then there will be required the follow-up every 3 months it is required. Next. So these are the points you have already discussed. So you have to give the patient information leaflet. What are the disease? What is cholesteatoma? What are the treatment options? Why you doing the mastoidectomy? What are the benefits of the surgery? What are the alternate treatment? So all things you in a leaflet you have to keep the patient. So patient will know what are the risk of complications. So here are the complications list. You have to mention everything, even the post-operative, post-oral scar. Sometimes we forget the numbness of the ear, you will not mention. But the patient will say after the if you create trauma to the chorda tympani, then there will be chances of alternation of taste sensation. That you should mention in your counseling part. So in the risk procedure, the complications you already discussed, I am not going, but these are the points you already miss, sometimes we miss, but that should be mentioned in the patient's leaflet. So these are the consent form. Actually it is not made by me, it is the association of it is given. This consent form is in our association ayho.org. There is a consent form, you have to follow it because here all the complications and all the things are mentioned and you have to sign by the patients. That's all you have to do for the counseling of the patients, because nowadays medical legal aspects are more important to us. Thank you.
Thank you. Now Dr. Ghotak and Dr. Gon take over with endoscopes, endoscopic surgery, endoscopic evaluation in chronic otitis media. Regarding counseling, I should say, don't scare the patient away, but make them aware of the difficulties that they may face post-operatively.
Ruhi madam has given an idea about the overall how you are going to manage the case. We will just discuss about endoscopes. So before this, what are the advantages that endoscopes are providing?
এখনো
ear surgery.
মল্লিক বাকি আছে, তোর হিয়ারিং রিহ্যাবিলিটেশন বাকি আছে। তো তো
A three-dimensional view of the a three-dimensional view of the middle ear and mastoid cavity, and which panoramic view.
Dada. Go on.
Anyone else?
The hearing.
A three-dimensional view or panoramic view of the middle ear and mastoid cavity, and also the extent of the cholesterol. All the structures will
We
be
do not
visible.
get three-dimensional view with endoscope.
3D view is more seen in
We get
microscope, no?
three-dimensional
Because
view
it
with
is
microscope, not with endoscope.
depth perception is better with the
Depth
microscope.
perception.
We can go and get a closer view in
Exactly.
single-handed
Closer,
endoscopic ear
it
surgery.
can be magnified.
Basically, there are two types of endoscopic ear surgery. One is single-handed, another is double-handed. Many people are doing nowadays double-handed. They are using a speculum and they are using the speculum to go advance the endoscope more into the deeper part and then coming out. But the advantage with single-handed endoscopic ear surgery, that is basically the main advantage of going from microscope to endoscope, or to have advantages. So what are the advantages? First is it is a wide angle view, right? Another is we can use a angled endoscope also. Apart from 0 degree, we can use 30 degree or 70 degree.
That is a very important thing, that the hidden areas that we have.
Say anterior epitympanum, the additors, the sinus tympani,
posterior
all these
tympanum.
areas can be seen beautifully with the, or the estrogen tube areas. You can see these areas beautifully.
Residual cholesteatoma.
Yes. If it is an early disease, you can also go and check the ventilation areas. What is the tympanic isthmus? Where is the tympanic? Whether that is open or not? Posterior isthmus. What are the?
So what are the two ventilation routes that we check with the endoscope? Isthmi that sir said, anterior and posterior. Where is the anterior one? Where is the posterior one?
Basically, this middle ear is of three parts. Okay. Above is epitympanum, middle is mesotympanum, and below is hypotympanum. So there is a diaphragm in between this epitympanum and this mesotympanum. So what is this diaphragm consists of? It consists of some bones, some ligaments, some mucosal and ligamental folds. That is it. All together they are making a structure just like abdominal and thorax. In between there is a diaphragm. Similarly, a diaphragm is there, and there are some potential communication between this mesotympanum and the epitympanum, through which the air passes, the air that you get in the middle ear with each bout of swallowing, the air goes into the mesotympanum, that has to go to the epitympanum, that has to go to the mastoid antrum and mastoid air cells via the additors and the attic. So there are these potential pathways are basically two in number. One is anterior tympanic isthmus, which is known as the main tympanic isthmus, another is posterior tympanic isthmus. So can anyone give me the boundary of anterior tympanic isthmus? Anyone?
Raise your hand.
Raise your, yes, follow.
Anterior tympanic isthmus extends from anteriorly tensor tympani muscle, then it is extended up to posteriorly posterior incaudal ligament, posterior superiorly and posterior inferiorly pyramidal eminence.
Yes, very good. And laterally?
And laterally head of malleus and
not head of malleus doesn't come. Why head of malleus
Head
doesn't come?
Head is component of the attic.
Why head of malleus? This concept has to be clear. Why head of malleus doesn't come?
Sir, it is in the epitympanic area.
Epitympanum is divided into two parts. One is anterior epitympanum, another is posterior epitympanum. Divided by what? One bony structure. What is that?
Cog.
Exactly. Cog is a coronal bony septum which comes down from tegment tympani to the processus cochleariformis. So head of malleus is a component of anterior epitympanum, right? So posteriorly you are getting body of incus and posterior epitympanum has got head of malleus and body of incus and short process of incus.
Anterior
Right?
tympanic recess and supratubal recess. That
So
is the
as you said,
anterior
anterior boundary is by the tensor tympani
fold.
Tensor tympani fold, right? Yes. So tensor tympani fold is getting attached to the neck of the malleus, right? So malleus is anterior to that. Now posteriorly, you are saying that posterior inferior ligament and the pyramidal eminence. So laterally will be body of the incus and short process of the incus. And medially will be the medial attic.
Yes, sir.
Medial vertical, right? So we are coming to this part is over. Next question is, How do you assess the patency of the ventilation pathways of middle ear?
There are two concepts to this. How will you assess it by the endoscope? Obviously, you will use the angle endoscope. And can you assess it in any other way?
Is there any other ways that you can assess?
Through a eustachian tube.
That will assess the patency of the eustachian tube.
Like pulse alva or Toynbee's method.
Shabby for eustachian tube basically. So
eustachian.
direct visualization
All
is
these
the
are
best
for
thing. With the angled endoscope. Why is it necessary? Why do you want to see the ventilation pathway? Will it have any effect on the post-operative outcome?
What are the theories of cholesteatoma formation?
Sir, in case of any
just name the theories. What are the theories?
So retraction pocket theory
number one
is important in
retraction
pocket theory, and there is a marginal cell hyperplasia, marginal epithelial migration, and basal cell hyperplasia theory,
yes,
and metaplastic theory,
yes,
and there is another implantation theory is also there.
What are the recent hypotheses for cholesteatoma formation? What are the current ones? These are not the current ones. These are all old theories. What are the recent two classifications are there? Two more. Cholesteatoma formation. The most accepted now is being accepted by many is the disventilation theory by the Marcioni, and another is mucosal retraction theory by Jacques. So these two are the recent hypotheses. So if we consider this disventilation theory, then we have to check the anterior isthmus in each and every case of tympanoplasty that we are doing, or any kind of middle ear surgery we are doing. Otherwise, we put the graft, and if there is disventilation or no ventilation to the attic area, then finally there is going to be retraction pocket formation and cholesterol. Okay. All other questions of endoscopic ear surgery are there.
Theory based.
You will get it there. These are all mostly theoretical. So no need to discuss.
The one question is, in this case, do you think endoscopic surgery can be planned? When will ওটা তো বলতে হবে আমরা যে কেসটা ডিসকাস করছি to what extent we can think about endoscopic surgery? In which case, I mean, is there any boundary যে বেশি হলে we will think of a combined approach or a microscopic approach? Exactly. So as we say, turning the corner.
What did he say?
Lateral canal ke touch korbe kina.
Yes, yes.
So if we can go up to the attic, but if it turns the corner, that is, it goes through the adytus and touches the lateral canal. If the sac is touching the lateral canal, generally it is not prudent to do an endoscopic surgery. Okay? So you
basically
should look for turning the corner.
mastoid surgery with the help of endoscopy is a debated topic nowadays. Many people say that we do complete mastoidectomy with the help of endoscope, but most of the time either they get an exoscopic view or a microscope to drill the cortex. If you consider only endoscope, then you can go up to the lateral sinus, lateral semicircular canal only, not beyond that. This is not possible.
So what is sir saying as
beneficial for small cholesteatoma in the mesotympanum, attic cholesteatoma, sinus tympani, or most of the time cholesteatoma sac of the fundus reaching up to the lateral semicircular canal. Okay.
What sir is saying that don't be dogmatic. It may not be possible to go with the surgery with endoscopes alone, but the difficult areas you can see.
So if the disease is progressing beyond that, then you can take the help of microscope. So it will be a combined microscopic and endoscopic mastoidectomy and plus minus tympanoplasty or ossiculoplasty. Right? So what are the advantages of doing endoscopic mastoidectomy in comparison to microscopic? Anyone? Yes?
Scarless surgery.
Scarless surgery, yes. So more cosmetic. And this is, and another is more functional surgery. Why more functional surgery? Because the disease, if you consider, disease starts from the posterior area or the attic area and then goes backwards towards the mastoid antrum and the mastoid ear cell. So if you are starting doing the surgery from that area only, so So this becomes more of functional. You are not damaging the cortex, mastoid cortex. That is the main advantage of mastoid air cell system. Okay.
And what sir has given the topic here, myotoplasty. Do you need myotoplasty in endoscopic surgery?
No.
Why?
We generally do not need.
Exactly.
But if the disease is going up to lateral semicircular canal,
then
it
we
is
have to
good to do some kind of myotoplasty. There are approaches of doing endural concomyotoplasty also. If you want to know, I can tell you later on regarding that. You may not go posturally, you can do it from endurally also. After doing the complete mastoidectomy up to lateral semicircular canal, the cholesterol removing, you are doing all kind of hearing preservation surgeries, and after that you can go for myotoplasty or concomyotoplasty even with that.
Done.
Bolo? He is asking why
এটা আসছে okay
I think that thing
we will discuss, but
that thing will be covered by Dr. Ruiz.
we are running out of time. We have taken half an hour extra, but we are still running out of time. This myotoplasty, again we run out of time of our operative time during surgery, and we neglect this part. So during exam also we do not know much about this myotoplasty. So I requested sir to tell you something about myotoplasty and ask you how much you know about myotoplasty. Sir.
Very rightly brought out, but in your generation probably this is going to get obsolete, as really brought out by the endoscopes. You will not need to do too much of a big myotoplasty. So as you know, what is myotoplasty? The two questions which have been framed are, how do you plan for the myotoplasty, and how myotoplasty helps in canal wall mastoidectomy. Anybody? Next? Who's the next speaker? Tell many points.
Hearing rehabilitation আর যাচ্ছে না।
You need to
Time
go.
নেই।
Okay, next.
Time নেই।
Front.
বিষয়টা লেকচার হিসেবে দেখাবো কি করে?
ওখানে যেরকম ভাবে আগেরবার দেখানো হয়েছিল।
See, basically myotoplasty is performed to widen the extra. What you do is basically to widen the canal to make it a single cavity. You have heard this term, no? You have to make it into one cavity. So you have to make the mastoid cavity and that is and the midlayer into one. So one of the things which was told you in the surgical aspect of Dr. Rui was you have to lower the facial ridge, right? So try to lower the facial ridge as much as you can so that you get one huge beautiful cavity. When you have one cavity, what happens, there are no hidden areas, the discharge can come out easily, right? So now what are the advantages? So what do you do? In my time, the wider the canal, the wider the myotoplasty, the better it is. So what are the advantages of a aim of doing a wide myotoplasty? Yeah, speak on. Take the mic. The more you speak, the better confidence you get in the exam.
As low as possible. So there a good myotoplasty will come to our rescue.
Absolutely, excellent. Yeah, good.
And we can clean it nicely. Moreover, a wide myotoplasty will fasten the healing as it will be well aerated. The cavity will be well aerated, and we can see the entire. The ideal end goal should be that we are able
so
to
you
see
should be able to see the complete cavity. So your myotoplasty should be wide enough so that you can examine the complete cavity. Right, good. So it provides adequate ventilation also through the mastoid cavity. Basically you have to keep it, so that there is the discharge is able to grow out. The debris which is there can come out. And you can watch fast whether the disease is, some disease is left behind inadvertently. You can catch that the disease is still there, right? If there is some residual disease, and it helps in the rapid myotalization. So what I should keep in mind is the most important one is that the anterior edge of the conchal cartilage, okay, that has to be removed. If you remove that, sometimes on my time we have to remove the complete conchal cartilage. You can see the whole complete cavity. So all that period is gone now. You have to just remove this. What you are finding over here, if you just remove that part, it gives you enough scope for to put your endoscope, and nowadays you have endoscopes. You have to put the seagull and just see that the seagull is able to see the edge of the lateral semicircular canal and whatever the edge of your the sinodural angle area. So all those areas should be seen, and excess excess underlying bone of the posterior cavity and all should be able to be seen. So what are the complications are of if you of this meatoplasty also? It's not that you just do it and you leave it or you make it a very small thing. As Dr. Somen said, this is the most neglected part, and actually it is the most important part. Because you may do a beautiful surgery, you may do a beautiful cleaning, but you have not done a meatoplasty, you will have debris present inside, you will have a discharge present inside and create problems. So it is actually a very difficult surgery because you have to balance the two. There is a cosmetic element, you have a big ear, and especially in a young unmarried girl, she goes in for a marriage, it looks, like it can affect the marriage prospects of that. So there's a cosmetic element nowadays, and you have to see whether the cavity is easily seen. So what is the post-operative assessment? What do you say is a good somebody quickly just tell me what are you going to say is a good meatoplasty?
So when the patient comes to us for follow-up, if without doing any maneuver and anything, we can see the entire cavity as it is, then we can say it's a good cavity.
Anything else?
এবারে যে যে বললো ভালো তাদেরকে না ওই
So if the cavity must be self-visible, it should be self-cleaning, there are no blind pockets, cosmetically acceptable, and try to maintain the auricular shape. These are the 4 points which you should maintain. Now there are a long list of, everybody is making their own kind of techniques, and now you have the endoscopic, you have the endoral approach, you have the post-oral approach. I'm just giving you this long list. You have a 2-stitch approach. So this is just one list which, and only stick to one thing in an exam. If you are asked how you're going to do it, be confident about one procedure and mention that procedure. There's a long list, it's beyond the time. Just read it up on your own and you can see it. There are certain names which you can tell in the exam of all these flaps and all these incisions. This is there in the slide. And last and not the least is, please remember you have pediatric cases also. So pediatric cases, as I said, keep that, the psychological factor of a big cavity, of a big meatoplasty can affect the child's development. But you must, as we said, is form a balance between the two. Right? So I'll stop here because of paucity of time, and you can get on with the slides. Thank you.
Last part, the hearing rehabilitation.
I will come to this later. First is, what are the options of hearing rehabilitation for a patient of chronic otitis media squamosal variety?
Bone anchored hearing aid.
No, just divide it. যাই কিছু করবে সবসময় একটু স্ট্রাকচার করার চেষ্টা করবে. Some will be surgical options, some will be non-surgical options. So non-surgical options, there will be hearing aid, conventional hearing aid, or bone anchored hearing aid, or there will be middle ear implants. That can be, that is also comes under, after surgery you have to deposit. Again, this is a non-surgical type. And surgical type, firstly this is squamosal otitis media, so you have to eradicate the disease. Yes. After that,
ossiculoplasty, sir.
Tympanoplasty, ossiculoplasty.
Yes, sir.
Both. Now, how can you surgically optimize this hearing outcome in a patient after master surgery? What is the most important ossicle that decides the hearing after master surgery? Which one? Anyone please get up.
So stapes.
Stapes what? Stapes?
Foot plate. Foot plate.
Foot plate. It's actually not stapes foot plate, but the stapes superstructure. Whether that is present or not. If that is present, you are at a peace. That yes, I can do a very good, I can give a very good hearing to the patient. What is that very good hearing? Having a post-operative earbone gap in a range of 20 to 25 decibel. So that is achievable very beautifully if the stapes superstructure is intact and mobile. Both these things are important. One is intact, whether that is present or not, and that is mobile or not. Okay. Now, what are the options that you can offer to the patient if the stapes superstructure is there? যদি সুপারস্ট্রাকচার থাকে কি কি অফার তুমি করতে পারো পেশেন্টকে কি
we can put a cartilage graft over the stapes foot plate from the malleus.
What kind of ossiculoplasty that is known as?
Then we Austin Cartus type A will be there, M plus and S plus. So 3B type 3B tympanoplasty, type 3 major columellar tympanoplasty.
Is this major? Is this major?
No, minor columellar.
Stapes superstructure is
present. Minor columellar.
Minor or
columellar.
POT type.
Yes.
Partial ossicular replacement prosthesis.
Yes.
Right? But if you are able to lower down the facial ridge up to a level that the graft will touch the head of the stapes, in that case, that will be known as
stapes columella,
right? Stapes columella. Another is short columella or minor columella. Now, suppose there is absence of stapes superstructure.
Yes,
then you have to assess the foot plate. Again, the same thing. Whether the foot plate is free from disease or not, number one. And number two, whether the foot plate is mobile or not. First, you have to assess that foot plate is mobile or not. How can you assess that? By touching the foot plate with a ball point probe.
Micropeak.
You can check the mobility of the foot plate. At the same time, you can check the round window reflex also and assess whether the foot plate is moving or not. If this is moving, then what are the things that you can offer?
A prosthesis we may put.
Which prosthesis?
Total ossicular reconstruction prosthesis.
TORP, total ossicular replacement prosthesis. Suppose in your operation theatre you do not have torque, what will you do?
Then
yes, give the mic to her.
Boomerang cartilage, maybe.
Boomerang cartilage. So how the boomerang is done? Boomerang ossiculoplasty. Boomerang cartilage is not boomerang ossiculoplasty. What kind of, where from do you get the cartilage for boomerang ossiculoplasty?
So we can harvest it from the conchal cartilage that we are already excising during myotoplasty.
Which part of the concha? Not all part of the concha will give you.
The Simba concha region, the bowl of the Simba.
No, that's the floor cartilage. That's from the floor cartilage you have to take. Otherwise, you won't get that much of cartilage. Any other option that you can do? Huh? No, cartilage is over. This is one boomerang is done. Any other ossiculoplasty that you can do in this case? Huh? Vibrant sound break you have to apply over the long process of incus. So incus is not there. The stapes superstructure is absent. That means all three ossicles are absent. Only you have a stapes foot plate intact and mobile. One option that has been given is boomerang ossiculoplasty. Another is umbrella ossiculoplasty, umbrella cartilage ossiculoplasty. Another is by Dr. Barin Rai Chaudhary has advocated piston through cartilage ossiculoplasty. These three are the basic options. Okay. Now coming to the another thing you can do if you do not have cartilage. Say this is a revision case and the cartilage you are not getting any cartilage, not the conchal cartilage, not the tracheal cartilage, nothing. What you can do? You can go for type 4 tympanoplasty. What is that? You will make a cavity smaller. That means you will include the cavity including the eustachian tube opening and the round window opening. You graft that area. So cavity gets smaller. Now take a full thickness skin or partial thickness skin and place it over the foot plate of the stapes. So you are exteriorizing the stapes. And in this way you are getting the phase difference. It is very important to maintain the phase difference to get a complete sound conduction from the external ear to the inner ear. So phase difference you have to get. So that phase difference is possible only by doing this technique. Alright, now suppose this is foot plate is present but that foot plate is fixed. What you are going to do? There may be many circumstances. Mastoidectomy, after doing mastoidectomy, hearing, surgical rehabilitation, there will be multiple things. Multiple circumstances will come at a point and then you have to take a call what you can do. So what you will do? No ossicles are there, only stapes foot plate and that is also fixed. What will you do? Huh? Which? Fenestration operation. Fenestration operation you can go for that. But will you do at this stage? Why not? Why you are not going to do fenestration surgery right now?
Granulation tissue is
Granulation
present
you have already removed.
and foot plate is fixed
why do not you want to do fenestration surgery right now, or if you want to do, why?
after limiting the disease.
What is this surgery? What is this case? This is squamosal chronic otitis media, right? This is an unsafe ear.
Yes, sir.
So you have to make it safe first.
Safe.
So it will be staged surgery. Not in one stage you will do fenestration surgery. You will do it, but after some time.
Yes,
maybe
sir.
3 months
After
or 6 months.
drying up
Till
the
the
cavity
graft takes up and this graft eustachian tube is covered. So you are making a smaller cavity including the eustachian tube opening and oval window which is fixed and round window. Alright. And after 6 months you will make a fenestration and do a TORP. All right. Thank you. Rest all the questions of hearing rehabilitation are in your booklet. You can check on that.
And those will be shared with you.
I would like to thank our moderator, Dr. Shomendranath Bandopadhyay sir, for having such a concise and a power-packed session regarding the CUM.